Good morning, everyone. I'm very happy to be here, and I'd like to also thank to Elixir to have us here for this presentation. I have a very short 3 cases, if you allow me to present different scenarios. So the first case is 60 years old, 46 years old male, a young guy. He has existed angina. He has diabetes mellitus. Ejection fraction is normal, and because of the CTO, patient offered cabbage, but it's refused the cabbage and came to us. So this is the LAD. As you see, because of the diabetes, I think it's a long lesion and it's a subtotal occlusion. And it's sure that this LAD is underfilling for some time, and we have negative remodeling, as we see in CTO. And here also, in CTO, we have almost all cases negative remodeling, but in here also we have a very tight lesion. The subtotal occlusion, I would say, maybe we have a channel, but I suspect that we have a good negative remodeling here. Anyway, we cross this lesion by help of microcatheter. I think it's nice to use micro here because it's subtotal occlusion, and pilot 50 crossed easily, and we did dilatation by 2.5 by 30, and then all the way, and then we do 2.75 and 3.020. This is all PTCA. And after this preparation, we have this vessel, and then we decided to put here dynamics, and we put 2 dynamics here, 3.038 and 3.523. The reason is why I choose dynamics here, actually. It's LAD is tapered vessel, distal is distal and proximal difference is huge, so it's mostly the most tapered vessel. So another thing that I know that we could have negative remodeling here, and after, if we have angiogram after 6 months, LAD definitely will be different than what we have now. So and I believe that by time after 6 months, this stent or Bioadaptor will give freedom of the enlargement of the vessel, especially for CTO. I'm a CTO operator. I believe this technology for CTO, it will help a lot. And another reason why I need to use an LAD in CTO, not here, but in CTO, 40% of the LAD CTOs we have bridge, and we don't see them because it's occluded. We don't see them, and then we just put the stent. But if we put, I believe, if you put dynamics, it may help again, because it's a bridge. This could be the result could be different than usual stent. Anyway, but we put 2 stents, and we did dilatation by 3.5 and 4.0. Of course, we did this intervention under help of IOS, and we did DCB very, very distally, and it was kind of hybrid case for us, and this is the result after 2 dynamics and 1 DCB at the distal. And we have at 1 year we had a angio follow-up, and also we checked IOS here, and you see we have a nice and big LAD. Even the LAD, if you compare, bigger than 1 year ago. This is the run first from distal to proximal. This is distal LAD. You have some plaque here, but it's fine. Lumen is good. And now we have Bioadaptor. You see, we could have some enlargement, and it's obvious that on OCD studies and other IOS studies shows that we have really, if you see here, we have really enlargement by pulsing, and it's more, I think it's more, especially for RCA also, I think the more natural we give, the bigger vessel we have, especially during the PCI. So sometimes we might not give enough nitro even in any PCI, so we could have undersized stents in our PCI, it's very common to implant undersize stent. I think this Bioadaptor may solve this issue as well. If we have really undersized stent, by time maybe we could have better lumen after uncage. This is case 2. Let me show you fastly. This is a proximal RCA lesion. Again, we did a 3.520 dilatation, and then we put a again long a single dynamics, which is 3.538, and then we did post dilatation here by 4.0 and 4.5. According to IOS, again, it's large LAD, and we did good dilatation by big balloons here, and it's tapered, as you imagine. And this is after result of post dilatation. And after 1 year, again, we have good result here. And it is really big. If you see LAD goes like this, it's mostly, this part is at least 3.5, maybe 4.0. And after 1 year, we have IOS, and it's really, there is no any hyperplasia. I think we have excellent result here. Approximately, even we did 4.5, still it looks to me is maybe we could do 5.0. It's a very big artery. So last case, 54 years old. He's class 3 angina, class 2 angina, smoker, diabetes. We have a left main plaque, but left main plaque wasn't significant. We have enough lumen. We didn't put any stent to left main, but we treat proximal LAD. It was very short use and calcified lesion. And I think this kind of patients we have to do very nice, as my colleague said, Ahmet Vakar said, good preparation and modification is very important. Maybe scoring balloon or cutting balloon may help. 3020 balloon first. And then we implanted 3.530. And we did, again, post-dilatation 4.0 and 4.5 proximal. This is final result. And we have, I think, good result here on 1 year. Even we have better result after restoring the vessel. So, you know, our vessel adapts our PCI after some time, because, as I told you, vessels become bigger and bigger after PCI. So it's nice to have something that adapts also that adapted vessel in terms of size. I like this concept a lot. And also this may help in acute coronary syndrome, because all of us know that acute coronary syndrome, mostly vessels are spasmodic, right? When you give nitro, you will have bigger. Another, I think, important indication for me, we could have underexpanded stent in calcified lesion. Sometimes, you know, we thought that we had good preparation of the lesion, but our stent may not expand well in some, and we will have definitely restenosis in that part. If we have, I'm thinking, if we have Bioadaptor, that part, if you know, if it is not a cage, then it will be easier to expand that stent after 6 months, because if there is no any link, you know, between strut, we could expand. Otherwise, it will be very difficult to expand in underexpanded stent, right? So we have, sometimes we had to do rod ablation. Why we do that? To break the link, to break some strut. So I think that's also, for me, we will see it, and by time, of course, we will have more experience, and then we will tell more these things. But in theory, I like this concept in calcified lesion for that. It's more forgiven to me. Okay, thank you very much for your attention.